And then what about heart failure? So we know that SGLT2 inhibitors are the mainstay of heart failure therapy, but now we have data. So if you look at the STEP-HFpEF and FLOW, and looking at that data for semaglutide, we have significant improvement in quality of life and in other impactful instances for patients with diabetes and obesity and heart failure. The SUMMIT trial for tirzepatide, and we'll talk a little bit more about those trials as we move forward. But why? Why do we have this occur? Decreased visceral fat, decreased arterial pressure, so improvements of blood pressure, decreased inflammation, improvement of glucose levels. So we know, although it's not on label yet, not indicated yet, we have improvement in heart failure. So when you're thinking about the patients that are in front of you, we need to think about what other things are going on with that patient outside of just glycemia. So we'll talk a little bit more about that evidence.
Yeah, and I think it's really nice to highlight that for years, we just had agents that lowered glucose. And that was really our goal, is a glucocentric. And now we actually have agents that not only lower glucose, but improve body parameters, improve cardiovascular risk, improve all those downstream complications. And when I'm talking to a patient, I'm actually saying, this particular medicine, maybe a sulfonylurea, just lowers your sugar. This agent does these additional benefits. And I think it actually is an important discussion point with our patients to talk about, this is why this is a good medicine for you. And then I think, yeah, please.
Yeah, and the other important point too is that it appears that the benefits of these therapies are really evident very soon after they're started. And so unlike, metformin is our old friend, and metformin is a very effective glucose-lowering medication, it took in the UK-PDS trials 10, 20 years of therapy before a true clinical outcomes benefit was detectable in the patients who were preferentially treated with metformin. Now we have the option of selecting therapies that will provide an outcomes benefit far more quickly. We know that the GLP-1 receptor agonists can all increase the risk of nausea. Interestingly, GIP receptor agonists are being studied as a means to manage nausea. So they're being studied as a monotherapy to be an antiemetic, for example. So it is thought that GIP receptor agonism actually can help to improve and manage nausea as a side effect. I don't think the GIPs have a major effect. Interestingly, the GLP-1 receptor agonists decrease glucagon secretion, and the GIP receptor agonists increase glucagon secretion, which you think might not be a favorable thing as far as effects on blood sugar go, but as long as you are taking or using a GLP-1 receptor agonist along with the GIP receptor agonist, that effect of glucagon on blood glucose levels is really not a concern. The GLP-1 receptor agonists decrease insulin sensitivity, and GIP receptor agonists increase insulin sensitivity. These are really drugs that directly do not affect insulin sensitivity. There can be some indirect effects on insulin sensitivity in people who lose weight, for example, but that's not primarily how the drugs work. And I would just point out that when we talk about all of these different mechanisms of action through which the cardio-kidney outcomes benefits might be conveyed, these are in large part theoretical. It's not really been proven that, for example, this effect on this one pathophysiologic process is the reason that these drugs provide an outcomes benefit. But there are lots of potential effects of GLP-1 receptor agonists that could be beneficial. And they're kind of bucketed here into indirect and direct effects. And what we tend to think about most are the indirect effects, because we know that the GLP-1 receptor agonists have a favorable effect on what we kind of think of as the traditional risk factors for cardiovascular and kidney disease, like weight, blood pressure, lipids, and then there can be some direct effects on coronary blood flow and left ventricular function that have been seen in preclinical data. But there may be direct effects as well that are a little bit harder to demonstrate, but that may be important as well. This first bullet basically is a long way of saying that the drugs do convey a bit of a natriuresis. They do promote modestly the output of sodium and water. There is thought to be improved tubuloglomerular feedback in the kidney, and as you can see, lots of other potential benefits that we talked about in one of the earlier questions. There may be downregulation of the RAS system, and we're really recognizing how overactivation of that system can have detrimental effects on the cardiovascular and kidney systems. There is thought to be, as a result of GLP-1 receptor agonism, a reduction in both systemic inflammation and organ-specific inflammation. This calls out here specifically inflammation in the kidney, but this probably happens in the myocardium as well. And then over the long term, this inflammation can result in organ fibrosis. So something that mitigates inflammation in those organs may have direct and beneficial effects on the structure of those organs as well. I'll show you a little bit of data about the effects of GLP-1 receptor agonism on the liver. GLP-1 receptor agonist therapy has been associated with reductions in hepatic transaminases. We're not talking about MASLD or MASH today, but remember that your patient may still have that condition even if their transaminases are not abnormal. In fact, once people's levels are kind of up in the upper third, maybe even half of your normal range, it's probably not completely normal. The drugs are associated with reduction in hepatic fat content, and there could be, again, a variety of direct and indirect ways through which these benefits are seen. Weight loss, of course, probably being very important, but also better blood sugar control, improvement in lipotoxicity, less insulin resistance, again, kind of indirectly. And there may be some direct effects on liver fat content. But when I talk about some of the emerging classes of incretin-based therapies, you'll hear about some emerging therapies that probably really directly do this. And again, GLP-1 receptor agonists, again, might decrease oxidative stress, maybe inflammation in the liver, and mitigate the risk of hepatic fibrosis.
And this is really just highlighting kind of the sometimes complementary and sometimes synergistic interactions between the effects of GLP-1 receptor agonism and GIP receptor agonism. And remember, our body secretes those. So this is really kind of doing this, kind of mimicking normal physiology. And it is important that when worked together, for example, effects on glucagon aren't going to end up in hyperglycemia because they're working in tandem with each other. And then really highlighting both the like the liver versus systemic effects. And really the body works as a unit. This is why we say the holistic approach. And I think it's important to recognize that when you look at things like glucagon metabolism, it's slightly different. Fat metabolism is slightly different. But used together or through the backbone of a GLP-1, you're really getting those extra glycemic benefits. So I'm going to briefly talk about clinical trial data, and I'm going to talk about it at a very high level, and mostly to think about how you're going to communicate this with your patients. Because, what I see a lot of times is when you're choosing an agent for your patient, you're choosing one not only because it's what you think clinically is indicated, but you might be choosing it because it's some extra glycemic effect, or it's going to get the person to goal. And I get lots and lots of consultations where someone has got an A1C of 14 and they're on 500 of metformin and 4 glimepiride, and I'm like, that's not going to work. That's really not fair for the patient, right? We need to make sure that we have a kind of a map of where we're headed. Which factor most influences your selection of using a GLP-1 receptor agonist or a dual incretin agonist for a given patient? Is it the dosing frequency, comorbid conditions, the cost of formulary access, route of administration, efficacy, or indication? You guys are doing great.
Yeah, and before we got here, we actually speculated of what we might see.
Yeah.
Here.
This question is tough, though, because these are not
Sure.
mutually exclusive, right?
Of
So it's a
course.
little bit of we're kind of working the system here, but we think about all of these things.
Yeah. And so when we had spoken about it, I think we kind of anticipated this, that even if we choosing with the other things, if you can't get it, that
We have to
becomes
live
an
in the
issue.
real world, right?
Sure.
What I want to call out is that 0% chose route of administration. So I don't know if you remember the days when we first had injectable GLP-1s and patients will never take injections. like that's been put to rest, right? I mean,
A non-issue now.
right.
For
And so
sure.
I think it's important to recognize that there are a lot of factors involved when you're picking an agent. That day of injection fear is largely gone. And so and we do have oral and injectable GLP-1s, and more are coming. But I think it is important to know that that should no longer be considered a barrier, and it's not a barrier by your answers. Anything jump out at you other than the
Well,
cost?
nobody chose dosing frequency either. I
Yeah.
think they're more alike than different now, to be perfectly honest. But yeah, so that's interesting. I wouldn't have expected 0, but there you go.
Yeah.
And I think probably, especially given this audience and the talk we're here, choosing comorbid conditions is certainly something we're thinking about for our patients. Do they have kidney disease? Do they have heart failure? Do they have ASCVD? But we still need to be able to get it to the patient and formulary and cost and so forth. So I think those showed up as two of the top choices.
And even before we put an emphasis on cardiorenal metabolic syndrome, the average person with type 2 diabetes had 7 medications, right? So polypharmacy is a big deal, and we got to choose agents that really can be potent and address multiple issues. All right, this question is a word cloud. So which patient demographic do you feel least equipped to manage when it comes to GLP-1 receptor agonist therapy? So now I think you're actually typing something in here. So please utilize your phone. Type in some things. Love it. You guys bring them in. That you'll see that the emphasis of the word will be emphasized based on the number of people that give the answer. It does look like the primary one has not changed to the whole thing, right?
Well, that's consistent with the pie chart, I think.
Yeah.
I don't know that we have time to address that in full today, but we can talk about some of the strategies, I think, when we have time.
What do you all think? What do you see here? What jumps out at you?
Uninsured, poor access, exactly what
Access.
everyone just chose, and that's important. And I think that has changed quite a bit over the years, and especially where we have data and we have indications and pending indications, and we take a look at the ADA standards of care, briefly we'll talk about today, of where these agents are positioned and chosen and recommended first because of the pleiotropic effects.
For sure.
So I see, of course, you've mentioned the access. I see concerns about frailty, people who are elderly, people who don't need to lose a lot of weight. We'll talk about that more at the end. Actually, pregnancy is in pretty large font here, and just to remind everyone, these are not agents that are recommended in pregnancy. I think the most recent data that I had seen was reassuring with respect to pregnancy outcomes in women who were pregnant and who were on these therapies and became pregnant, but really it cannot be recommended. And remember that a lot of our patients have RN or oligoovulatory, and when they start these medications and lose weight, they will ovulate often more regularly. And so it is important for when you're starting a medication like this in a woman of childbearing age to make sure that you're also talking about contraception. There can be very big surprises if someone loses, for example, 10, 15% of their body weight on one of these medications.
And it is happening. There has been a
yeah.
whole set of literature about people who have gotten pregnant on one of these agents. And so far, you're right, the data is reassuring, but that in no mean is a nod to utilizing those agents.
Right. And women with diabetes and women with obesity are at high risk for adverse pregnancy-related outcomes to begin with. And then when you're managing an individual person and they have an adverse outcome, it's very difficult to know or understand or be able to explain whether or not that is related to the disease state or to a medication that they might have been on. So it's really best to do everything you can to be proactive, to minimize the likelihood that this would occur.
Yeah. And one thing I see here that I can understand, but I'm excited about is children. And one of my areas of research is utilizing these agents in children. I have substantial, maybe 12 years of experience utilizing them. And there's a lot of exciting news coming. None of them are FDA approved today. Actually, that's not true. There are some that are approved in age 12 and up. But these are very potent agents, and they work well at a time when someone is very insulin resistant in adolescence.
Yeah, and adolescents have a disease that behaves differently than in adults. They progress much more rapidly, and the medications tend to not work as well when it comes to blood glucose lowering. So that's a field that needs a lot more study.
So this, as we take a step back just for glucose lowering, and I utilize this when I'm doing kind of resident education and things to say, when you look across your spectrum of available GLP-1 receptor agonists, they all lower glucose very well, right? We've got liraglutide at 1% mean, and again, many of the oral agents are less than that, and then you just go up from there. And so you'll see that some of the guidelines will highlight mild, moderate, and high potency. And again, you should choose your agent based upon how far you are from goal. Like, give the patient the best chance for success. And so you do see you've got at least 2 here that get more than 2% A1C reduction. And this is important because I want my patient to know what to expect when we're using those agents. And while you start low and go slow, you can titrate to that benefit that you need to get. And then this is looking at the sustained series of trials. And when you look at this, and this is semaglutide 0.5 and semaglutide 1.0, you can see across the spectrum of trials that in addition to glucose lowering, you're getting significant weight loss compared to the comparator, whether that's placebo in gray or dulaglutide in orange, exenatide ER in yellow. You've got a DPP-4 in there somewhere, as well as in red. That's again dulaglutide. So you do have, again, significant benefit. And this really changed the conversation for a lot of my patients, because I used to say for every 1% you dropped your A1C, you got a 6-pound weight gain. That was kind of the lived experience before we had this class of agents. And now we can say we have agents that are not only going to help you achieve your A1C goal, but also have substantial reduction in your weight in addition to that. And that's really what a lot of patients want, because they get frustrated when you say, oh, your A1C is so much better, but my weight is higher. And I'd also highlight that this is even before we had the 2 milligrams of semaglutide for type 2 diabetes. When we look at the SURPASS trial, again, the series, this is again looking at tirzepatide in patients with type 2 diabetes. And again, looking compared to the comparators, and again, I'm calling out the asynchronous climb of these agents. This is again only looking at the semaglutide at the lower dose. You do see that you get, again, substantial weight loss with all in a dose-dependent manner for tirzepatide, all the way up to 15 milligrams. And again, in many of these trials, you're getting more than 10% weight loss. And it is important to call out, and I think the next slide shows it, that you're going to get a little bit less weight loss with any of these agents in people with diabetes versus without. And so I think it's very important to make sure you set realistic expectations with your patients. I don't know if you guys want to add anything to that.
I was just I was thinking, sitting here thinking historically before these existed, and I can almost see patients in my mind when I'm telling them that I'm putting them on a glitazone and it's the best thing and it works so great, which it does. But, when I think about what happened to them, in terms of weight gain, that this is almost like science fiction. So we not only have the glycemic reduction, but weight loss, and then all the other pleiotropic effects. So, when I think about what did I teach, 30 years ago and 20 years ago, it's crazy.
In my practice, essentially people would come to see me and I would say, let's go up on this dose and that dose and that dose of insulin. That was the endocrinologist practice, the diabetologist practice. 15 years ago was changing insulin amounts and maybe changing the mode of insulin delivery. So it is a whole new world for type 2 diabetes.
500.
Yeah.
It's incredible.
Very different.
Now, this is the SURMOUNT-5 trial. So again, in the absence of diabetes for the management of obesity. And you can see then that both semaglutide and tirzepatide gave you more than 10% weight loss. In this study, tirzepatide had 20% weight loss. And I think this is really a major component that I want you to think about. We always are talking about lifestyle management as part of diabetes, and we always talk about trying to lose weight, but we know that there are thresholds. 3% is going to improve some of your numbers. 5% can really improve some of your risk factors. 10% is disease modifying, and 20% is often disease regression. And so I think as we think about the things that are hurting people with diabetes, getting that 10 or greater % weight loss is really critically important. And that's why these have been good agents, not only just for weight loss, but for the outcomes associated with excessive weight. And I want to highlight here, if you even look in the middle there, those at 10%, 15, 20%, 25%, with both agents, you're getting more than a 60% achievement of 10% weight loss and as high as 81%. That's a really big deal. And that, we don't have the A1Cs here, but the A1Cs are also dropping now below the diabetes range into the pre-diabetes range or even into the normal range. I would be thrilled if I could get my patients with type 2 diabetes to have 40 to 65% get 15% weight loss. That's going to change the trajectory of their disease. And so we now know that we can feel really good about working with these patients, giving them agents that are going to be patient-centered goals, but also help us achieve our goals.
And we have to think about this, the ability to de-intensify therapy.
Yes.
So we can de-intensify therapy by less medications. People have that level of weight loss too. It could even be blood pressure meds and not just diabetes medications that are decreased because of this.
Yeah, I love that.
Now I'm going to move on to my favorite, the trials looking at cardiovascular and kidney outcomes benefit. Obviously, I'm moving on from the metabolic benefits. So I'm just going to very briefly summarize some of the findings from some of the most recent and key outcomes trials studying the effects of GLP-1s in dual incretin therapy. So the SOUL trial was a big deal, and this was published, I think, not long ago at all, earlier this year. And this was a trial that enrolled about 9,500 participants with type 2 diabetes and known established atherosclerotic cardiovascular disease, chronic kidney disease or both, and randomized them to either oral semaglutide or matched placebo. And essentially, you can see here the Kaplan-Meier curve showed that being assigned to oral semaglutide therapy significantly reduced the risk of major adverse cardiovascular events compared to placebo. You get about a 14% relative risk reduction, and this was over a median of 49.5 months of follow-up, and this was a highly statistically significant difference. So for our patients who, and there are some of them, I think they're more likely managed in primary care than the endocrinologist practices or diabetologist practice. There are people who really just want to be on an oral medication, and now we know that oral semaglutide is a good choice and something that will provide both a metabolic and cardiovascular outcomes benefit in these higher risk patient populations. This is a slide that really just summarizes some of what we've learned about the effects of GLP-1 receptor agonist therapy and heart failure. And there's a lot going on in these trials. These aren't all heart failure specific trials, but they're trials that look specifically at the effects of semaglutide compared to placebo in patients with heart failure and either moderately reduced or preserved ejection fraction. So this is a pooled analysis of SELECT, which was a trial of people with obesity and established atherosclerotic cardiovascular disease, FLOW, which was people with type 2 diabetes and chronic kidney disease, and then the STEP-HFpEF and STEP-HFpEF-DM trials, which looked primarily at functional status in people with HFpEF treated with semaglutide compared to placebo, but in which a few hard outcome events occurred and were included in this analysis. So when all of these data were analyzed together, looking at the effect of semaglutide on a composite outcome of cardiovascular death or worsening heart failure, overall you see a reduction of a relative risk reduction of 31% in this composite outcome, again, of cardiovascular death or worsening heart failure with semaglutide treatment in patients with moderately reduced or preserved ejection fraction heart failure. So really a lot of data emerging. And then importantly, the SUMMIT trial, which looked at the effect of tirzepatide compared to placebo in patients with HFpEF and obesity. And again, you see here with a difference pretty visually emerging at about 2 years in this population of people, that tirzepatide therapy led to a lower risk, again, of this composite outcome that is used in a lot of these heart failure trials, again, a composite of cardiovascular death or worsening heart failure compared to placebo. The hazard ratio for that outcome being 0.62, pretty impressive with tirzepatide therapy compared to placebo. And again, this was a statistically significant significant outcome. And importantly, the results, the effects of tirzepatide were similar in people with and without type 2 diabetes. So it is always important to look at that breakdown. Now, I was very happy to see the results of the STRIDE trial because peripheral arterial disease seems to be sort of the forgotten complication, and our patients have it. And our patients with peripheral arterial disease are at very high risk for not just complications related to their peripheral arterial disease, but they're also at very high risk for cardiovascular death, MI, and stroke. Don't forget, it's not just their legs that are the problem. This is an indication that they have a higher global cardiovascular risk. But the STRIDE trial was a trial that looked primarily at the effect of semaglutide treatment in people with type 2 diabetes and peripheral arterial disease on functional status. So again, it enrolled patients with type 2 diabetes and PAD that was symptomatic, so that limited their ability to exert themselves. The primary outcome was the ratio of end of study to baseline maximum walking distance. And people who were assigned to semaglutide treatment had a very significant improvement in their median walk distance at the end of the trial. And not shown here, but important to understand, is that the difference between the semaglutide treated groups and the placebo treated group was about 52 yards, if I remember correctly. So it wasn't just a couple of yards more that they were able to walk. It was a pretty substantial difference overall. The FLOW trial we've alluded to a couple of times already. This was a trial that enrolled people with type 2 diabetes and chronic kidney disease. They were randomized to semaglutide or matched placebo. And again, you can see here with at least visually a difference in outcomes of the two groups being evident certainly by 1 year of treatment, where you see that semaglutide significantly reduced the risk of the primary composite outcome, which was comprised of a 50% or greater sustained reduction in eGFR, progression to kidney failure, or kidney-related or cardiovascular death, with the hazard ratio being 0.76 with a highly significant p-value 0.0003. So again, there are accumulating data now in a dedicated kidney outcomes trial that the GLP-1 receptor agonists significantly reduce clinically important kidney and cardiovascular outcome events in this high-risk patient population. And then the final kind of category or disease state that I'll show data about include the effects of the incretin-based therapies on fatty liver disease, or MASLD, or MASH is the current terminology. So these are data from the ESSENCE trial. This trial enrolled patients with MASH and stage 2 or 3 hepatic fibrosis, with the endpoint that was of interest being resolution of steatohepatitis without worsening of hepatic fibrosis. And you can see on the left-hand side that with semaglutide treatment, that endpoint occurred in about 63% of treated participants, whereas with placebo, that occurred in a smaller proportion, 34.3% of placebo-treated individuals. Smaller proportions had reduced liver fibrosis without worsening of steatohepatitis. However, that was more likely to occur with semaglutide treatment therapy compared to placebo. You know, one of the things that I forgot to mention previously, but that you can see displayed pretty well on this slide is sometimes it's important to kind of keep an eye on what the optimal or target treatment dose of the GLP-1 or dual incretin agonist was in all of these different trials. And what you see consistently is, for example, let's take semaglutide as an example. In the trials that are really focusing on patients at high risk for cardiovascular and kidney related outcomes, usually the target dose was 1 milligram a week. If the trial enrolled patients whose primary problem and whose primary comorbid conditions were related to excess weight, the treatment dose, the target dose is usually higher, as you see here, where the target treatment dose of semaglutide was 2.4 milligrams weekly. So keep that in mind. If you want to improve cardiovascular kidney outcomes in patients, for example, with type 2 diabetes and established ASCVD or established chronic kidney disease, A semaglutide dose of 1.0 appears to be effective in improving outcomes. But for some of these conditions like HFpEF and MASLD or MASH, that really are very highly dependent upon and related to excess adiposity, you're going to want to try to go higher to reproduce the outcomes that we're seeing in these trials. And then finally, this is a similar trial called Synergy NASH of patients with MASH and moderate or severe hepatic fibrosis randomized to tirzepatide at one of 3 doses or matched placebo for 52 weeks. And you can see here that tirzepatide was more effective than placebo with respect to the outcome of resolution of MASH without worsening hepatic fibrosis. And on the left-hand side, this particular outcome and the benefit of the drug appeared to be dose dependent. For this secondary outcome that you see in a lot of these MASLD MASH trials, the decrease of fibrosis stage by at least 1 stage and no worsening of MASH seems to be a little bit harder to move the needle on, but again, the active therapy being more significantly effective than placebo. Just a reminder that what we have available now, we have a lot of tools in the toolbox to manage our patients with, but there's so much more coming. And this was a very recently published, this is from a very recently published fabulous manuscript by Dan Drucker that was published in April of this year. It's already a little bit out of date because the field is moving so rapidly. And what's shown here at the top of this original chart in the manuscript, you see this little figure that's all in the kind of turquoise, the light blue color. That represents essentially the GLP-1 or GLP-1 receptor agonist sort of molecule. And now what's being shown here is what's been built upon that sort of shape, structure, molecule, and what we can expect to see in the future. We already have seen quite recently results for some of these agents. So if we look at the top right, orforglipron, or Orfo for short, is a small molecule orally administered GLP-1 receptor agonist that has glycemic and weight outcomes benefits demonstrated in clinical trials. The results of a couple of CAGRI-SEMA trials, which is a combination of a GLP-1 and amylin receptor agonist, shown demonstrating very significant improvement in weight, as well as hemoglobin A1C in the patients with type 2 diabetes studied in those trials. You see tirzepatide here is already available to us. To the left of that at the top, retatrutide, which is a tri-agonist, which is fairly far along in clinical development. And this is an agent that provides both GLP-1, GIP, and glucagon receptor agonism. The really fun thing about these glucagon receptor agonists is that when you think about it, glucagon is really a signal to the liver to like provide a lot of energy into the systemic circulation. So what you often see in trials of agents that include agonism of the glucagon receptor is that a huge amount of hepatic fat will be mobilized when people are treated with these agents. So it'll be really interesting to see what the effects of these drugs will be in people with MASLD and MASH. But again, lots of other classes, types of agonists that are becoming available. You have, for example, a lot of emerging interest in amylin and amylin receptor agonism, which kind of fell out of favor in the past because as the therapies that we had available in the past were difficult to take. But lots of really fun agents that will be coming down the pike. And we should have a really, if the majority of these are successful in their clinical development programs, we'll have a lot of options to treat our patients with. And we can truly, I think, provide individualized treatment options for our patients.
So let's talk a little bit about the standards of care. And you know, we have kind of alluded to that. And I think that everybody truly understands that we need lifestyle changes, certainly goes with it. But the real change that happened a few years ago is not metformin for everyone. And that's because we're no longer glycemic centric. We're not looking at just glycemia. What we're looking at is the pleiotropic effect. So if we have someone with high risk, the standards of care are recommending specific drug therapy outside of that glycemic control. So if someone has ASCVD, if someone has high risk or indicators, the recommendation is to use the drugs that have the data and the evidence and the indications. So GLP-1 receptor agonist with cardiovascular benefit, or an SGLT2 inhibitor. Then we're looking at glycemic control. If we need additional glycemic control, use the opposite. So if you started with the GLP-1, we're going to add an SGLT2 inhibitor. If you started with an SGLT2 inhibitor, we'll use a GLP-1. And as we kind of discussed earlier, is using that combination therapy. We're seeing data on that, but it's not mandated. It's not in the standards of care. The other thing is heart failure, and we've talked about now the SGLT2 inhibitors being standard go-to, but now we have that data that you have reviewed on semaglutide and this tirzepatide, so put a pin in that. They don't have the indications as of yet, but it's certainly hopeful. And CKD, for sure, SGLT2 inhibitor or GLP-1 receptor agonist that has that data, and we have that indication. And then also thinking about mitigating the risk of liver issues, for sure. Then the other flip side of it is the obesity and glycemia. So yes, we care about those pleiotropic effects, but certainly obesity, when patients are sitting in front of you, what's the most important for them? And what we saw with the highlighted data that you both have gone over is for efficacy for weight loss, the very high would be semaglutide injectable and tirzepatide. And then for glycemic control, the same thing, very high would be high-dose dulaglutide, tirzepatide, and semaglutide. So, we have talked about this. So for everybody, lifestyle changes, weight loss, cardiovascular risk reduction, we're going to take care of patients, going to make sure that blood pressure is under control, cardiovascular risk, et cetera. But early on, obesity pharmacotherapy versus diabetes pharmacotherapy, the preferred is going to be GLP-1s, GLP-1 receptor agonists, the combination with or without pioglitazone, SGLT2 if you have type 2 diabetes. Same thing if you go up with your risk a little bit higher, which you can see here, but specific MASH pharmacotherapy, that's a little bit later. And one of the questions that we asked was the polling question was about decompensated. And so at that point, it's a different ballgame and a different story.
Let's start with our first case. This is James. He's a 65-year-old man who was diagnosed with type 2 diabetes about 12 years ago. He currently weighs 232 pounds, which corresponds to a BMI of 34.1, and his weight is up 12 pounds in the past year. Currently, his hemoglobin A1C is 7.4%, on a regimen of insulin glargine 50 units once daily and metformin 1,000 milligrams twice daily. With respect to his diet, he's currently eating out about 4 to 5 times a week, and he also notes that he's been having more snacks in the evenings. With respect to his comorbidities, he has hypertension, for which he takes lisinopril. He has osteoarthritis. He does not have a history of atherosclerotic cardiovascular disease. Of note, he does have insurance comprised of Medicare Part D, which has an open formulary. So this, in fact, is a very common clinical scenario in my clinic. And James is on a very high dose of basal insulin, as well as metformin, which is clearly an indicated medication, which would be started early in the course of type 2 diabetes. However, his hemoglobin A1C is not a goal. It's not far, but certainly a target of at least less than 7% would be very reasonable for him. But this is a common scenario where he has been eating more, has been eating out, and has been consistently gaining weight on his current regimen. Of course, this is very likely contributing to the fact that his hemoglobin A1C is above goal. So it will be very important, of course, in addition to any medication changes that would be made, to ensure that James spends some time with a nutritionist or a dietitian to talk about strategies to, for example, minimize the number of times that he is eating away from home during the week. And perhaps if he is very interested in continuing to have snacks in the evening, that he can make lower carb, lower calorie choices. And these will all be helpful, but they may or may not be adequate to both address his weight gain and his inadequate glycemic control. So in James's case, it would be very much appropriate to add a GLP-1 receptor agonist at this point. The ADA recommendations in their current format recommend that for patients who are on basal insulin, that they also be treated with a GLP-1 receptor agonist or a dual incretin agonist, for example, such as tirzepatide. It has been shown that compared to basal insulin alone, that the combination of a basal insulin and a GLP-1 receptor agonist is more effective in achieving glycemic control with a lower risk of hypoglycemia and lower risk of weight gain than if insulin is used alone. So that would be a very appropriate next step. Because James is on a fairly high dose of insulin glargine, we would want to be certain that we understood whether or not that dose needed to be adjusted when he started the addition of a GLP-1 receptor agonist. So he should be monitoring his blood sugars at home, either with the CGM, or if for some reason that is not his desired way to monitor, or it's not available to him, with finger sticks, particularly paying attention to the fasting blood sugars as the GLP-1 receptor agonist is added and the dose is up titrated. Our second case is Lena, and this is a case focused on management of people with type 2 diabetes and renal disease. So Lena is 64 years old, and she is a woman presenting to her primary care clinic for routine follow-up of her type 2 diabetes. She was diagnosed with type 2 diabetes 10 years ago, and currently her hemoglobin A1C is 7.9% on several medications, including metformin, 1,000 milligrams twice daily, glipizide, 10 milligrams twice daily, and empagliflozin, 25 milligrams per day. Her other medical conditions include hypertension, dyslipidemia. She has obesity with a BMI of 31. And 4 months ago, when she was seen in clinic, she was found to have an elevated urine albumin to creatinine ratio. With respect to her social history, she does not smoke or drink alcohol. She has been fairly active, walking 1 hour, 3 days per week, but she sleeps poorly. She does live with her spouse, and she has a fairly sedentary job working as an accountant. Her other medications include losartan, 100 milligrams daily, atorvastatin, 40 milligrams daily. Her vital signs at the visit include a blood pressure of 128/82, a heart rate of 78, and a respiratory rate of 18. Her relevant laboratory data include an eGFR of 54, a urine albumin to creatinine ratio of 388 milligrams per gram. Serum potassium is 3.9, and the remainder of her chemistries are within normal limits, as is her CBC. Total cholesterol is 188, her HDL is 42, her LDL cholesterol is 90, and her triglycerides are 146. So there are many, many things to address in Lena's case. It's important when we are designing a regimen of care for people with type 2 diabetes that we very carefully consider what complications or comorbidities they may have so that we can tailor the treatment regimen appropriately. Lena has a diagnosis of renal or kidney disease, and assuming that she has had these persistent EGFR and or UACR abnormalities for at least 3 months, we can fairly confidently say that she has chronic kidney disease. In people with type 2 diabetes and chronic kidney disease, in addition to, of course, making sure that their blood sugar and blood pressure are well controlled, we need to ensure that she is on medications which will specifically address the risks associated with having chronic kidney disease, including, of course, the risk of progressive kidney disease, but also the associated risk of cardiovascular complications. Looking at her medication regimen, she is very appropriately on empagliflozin 25 milligrams per day, which should provide cardioprotection. However, we need to think beyond her current regimen because, as you can see, her hemoglobin A1C is not adequately controlled. And certainly for a 64-year-old woman with kidney disease, I would want her hemoglobin A1C target to be at least under 7%. She also has comorbidities, including dyslipidemia, hypertension, and obesity, which may respond favorably to the addition of a GLP-1 receptor agonist to her regimen. We know from the FLOW trial that semaglutide in particular has been shown to reduce the risk of progressive kidney disease and cardiovascular complications in people just like Lena. So it would be quite appropriate as the next step to add, in particular, semaglutide to her regimen, as that is the agent at present with the most clearly demonstrated outcomes benefit in this patient population. Now, as the GLP-1 receptor agonist is added, it is very important to take a look at the existing diabetes regimen and to think proactively about whether or not adjustments in that medication regimen might be necessary. In particular, as the GLP-1 receptor agonist is added and the dose up titrated, I would be concerned about the current dose of glipizide and might even proactively reduce that dose by half when the GLP-1 receptor agonist is added, and probably would have the goal of eventually taking her off the glipizide altogether once the dose of the GLP-1 receptor agonist was adequate to permit that and maintain her target level of glycemic control. In particular, because she is on a regimen currently which includes the sulfonylurea, it would be very appropriate for her to be monitoring her blood sugars carefully at home, either with a CGM if she has that available to her, or with fingerstick blood sugars. Often when the GLP-1 receptor agonist is added, what we see first is an improvement in postprandial blood sugars. So it would be very reasonable for her to check her blood sugars after meals or prior to meals, but the fasting blood sugar should be monitored as well to determine whether or not the glipizide dose would need to be further decreased or discontinued. For her long-term management, her blood pressure is reasonably well controlled, although more recent guidelines suggest that for her, a target blood pressure might in fact be, a target systolic blood pressure for her would in fact be less than 120, and that could be considered as a target if she were able to lose weight with the addition of the GLP-1 receptor agonist. Her blood pressure may improve as a result. She is very appropriately on a moderate dose, a moderate intensity statin regimen. Her LDL cholesterol is 90. Because she has chronic kidney disease, it would not be unreasonable to consider a lower LDL target, for example, less than 70, because she is at elevated risk for cardiovascular events. Our third case is Danny. Danny is a 47-year-old man who has type 2 diabetes and obesity. In the past, he was managed with metformin. However, more recently, he was started on semaglutide therapy, the dose of which was recently titrated up to 1 milligram per week. He has some lifestyle challenges. In particular, he has missed some recent diabetes education and medical nutritional therapy appointments. He has struggled with giving up what he calls game snacks, and in fact has asked about periodically stopping the semaglutide during weeks where there are a lot of games that he likes to watch. He does note that he's been experiencing some mild nausea since the dose of semaglutide was escalated. However, he's had no vomiting, diarrhea, or abdominal pain. He reports that he really hasn't lost much weight yet. And in addition, he feels like the medication is not really very tolerable for him. And he's asking if there's an easier option that might agree better with his GI tract. This is a very common scenario, and this is a situation also where counseling can be incredibly helpful in ensuring that people are able to successfully up-titrate and continue to take a therapeutic dose of a GLP-1 receptor agonist. First, it is very important to start the medication for the first time at a low dose and to up-titrate the dose of the GLP-1 receptor agonist slowly. Although the doses can often be up-titrated as often as every 4 weeks, in my experience, if a person is already or continuing to have GI symptoms on a current dose of a GLP-1 receptor agonist, it's best to wait a bit longer until they're really feeling well before the dose is up-titrated further. We don't really know what happened historically in his care, but he may have needed a little bit longer on the previous dose to make his transition to his current dose a bit more smooth. However, we can tell from the listed history here that he probably is making some choices that are contributing to his continuing to have both GI symptoms and perhaps not as much weight loss as would have been desired. So when I start people on a GLP-1 receptor agonist, I explain to them first that they may feel less hungry. This is not the case for everyone, but it is very common. And it's important for people to understand that that is an expected side effect of the medication. In order to minimize the likelihood of GI side effects such as nausea and vomiting, I also counsel people to try to spread their food intake throughout the day so that they're eating multiple small meals rather than 1 or 2 very large meals. And in fact, eating large meals infrequently or not eating during the day and then in the evening eating a very large amount of food over an extended period of time is in fact a fairly common eating pattern. And it is important to talk with patients before starting the medication to understand if that is how they are currently getting in their calories. So again, spreading the food out, avoiding having very large meals at any one time, and counseling people that they may not feel well if they continue to eat the same amount of food at mealtimes as they have been used to. This will go a long way towards setting expectations and setting people up for success as well. People always need to know that they may have GI side effects, particularly when they're first starting the medication and when the dose is being up-titrated. So the most common side effects would be nausea, for example, or loose stools or diarrhea. Vomiting can occur, but fortunately that is much less common. Another commonly reported side effect that may not be spontaneously mentioned by the person taking the medication, though, is constipation. So it is important to ask about constipation as well. Counsel patients that, again, if the problems may be, the side effects may be most noticeable at first, and then when the doses are up titrated. And if they can be very careful about avoiding the intake of very large meals, very high fat meals, and even food that's very spicy. That will minimize the likelihood of their having problems during these very critical points in time. This patient really probably needs to sit down with the diabetes educator, nutritionist, and/or dietitian, and perhaps all of the above, to really carefully review his eating habits and come up with a plan that will both make him happy and satisfied with the amount and type of food that he can comfortably eat, and that will permit his continued use of the medication. In particular, his potential intermittent use of the medication is probably contributing to his likelihood of having adverse GI side effects. So consistent use is important. And if it remains a struggle, it might be most appropriate at the present time to drop back to the previous dose for a period of time to let his body readjust and for him to try some agreed upon dietary changes so that he can more successfully up-titrate the dose of medication in the future. But forewarned is forearmed and very likely to make the transition to an up-titration of a GLP-1 receptor agonist much more successful.
So you all did a fabulous job with questions, and we had pre-planted some kind of scenarios to talk about, but you got them. So we're going to talk about your questions. So I've got them coming in, and some are going to be for all of us. Some I'm going to direct. So the first question that came in, and I'd like to hear everyone's thoughts here, but I'll start with you, Jennifer. How do you handle interruption of these agents when it comes to a procedure or a surgery for a patient?
That actually is a bigger question than you might have intended. There have been concerns expressed, for example, that people who are on one of these agents that in theory slow gastric emptying, who are going for a procedure in which they receive general anesthesia, might increase the risk of aspiration events due to retained gastric contents. Now, I would say that the data to support this as an actual concern are very limited. And in fact, analyses of large data from healthcare systems, from insurers, suggest that the rate of aspiration in people on a GLP-1 or dual incretin agonist before they receive general anesthesia, that the rate of adverse outcomes related to aspiration or respiratory failure is comparable to people not taking them. However, we need to work with our colleagues. And what I see recommended most often is that, for example, if someone's on a weekly GLP-1 receptor agonist, that they take their last dose a week before the procedure so that the effect is kind of waning. Every once in a while, I hear kind of concerning stories where the anesthesiologist or surgeon has recommended that they stop it for a month beforehand, which I think is very, very difficult to justify and is likely lead to a decompensation in glycemic control for many people. So I personally would push back against that if that's an issue. Now, you might be asking a different question, though, and that is, I can let somebody else answer this, but then when somebody's been off for a while, because they've been in the hospital or they're recovering from a procedure, then what do you do?
I think it depends. It's going to depend on how long they're off. Because if we think about the weekly agents, semaglutide has a half-life of 7 days. So even if they missed a week or missed a couple of weeks, there's still semaglutide present. Tirzepatide has a half-life of 5 days. So they're long-acting. That's why they can be dosed once a week. So if somebody missed a week or two and they don't have GI issues before, I'll have them I choose to have them restart at their previous dose. If they're off for months, then I might restart. What
Especially if it was a struggle the first time around to get them to tolerate a therapeutic dose, you might want to be a little more conservative.
There was actually a recent study that showed that if you fasted 24 hours before surgery, you actually had the same benefit if you held the GLP-1 for some length of time. Because quite honestly, the GLP-1 holding data is very inconsistent, and the recommendations actually don't make physiologic sense. So actually, I have found, and I've seen the anesthesiologists I'm working with are okay with that if they do fast or only water for the 24 hours before. And then you don't have that issue.
Absolutely.
Okay, so Jen, I got one for you. What medication should you be careful about due to GI absorption issues when starting a GLP-1 receptor agonist?
There's really no clinically significant drug interactions for that purpose, other than what you had talked about earlier in terms of fertility, right? So in terms of birth control, tirzepatide, the recommendation is actually need to be at steady state for that 4 weeks at each dose change. So using an alternative when you're on tirzepatide, one IUD or whatever, or waiting until that. Now, that recommendation is not there for semaglutide. However,
In the
you have
US.
that weight in the US. However, you have a weight loss, you have other reasons have improved fertility. So it might just be good clinical judgment or appropriate to have that conversation in your childbearing patients.
Yeah, so if their primary means of contraception is oral contraceptives, they might, for a little while, want to have a backup form of contraception being used as well. So the question is, we don't see this with other classes of medications. I don't know that it's as well studied. I think the issue is that the risk of becoming pregnant on one of these drugs is really unknown and is not recommended. And so if someone, oral contraceptives are kind of a special case where you're potentially affecting outcomes of 2 people rather than just one. And the European Medicines Agency has taken a kind of, they have much more sort of specific language calling this out as a potential concern, really for a lot of the GLP-1s and dual incretin-based therapy.
So this is a common question that came throughout. What's your approach for switching GLP-1 receptor agonists, especially when cost or formulary is an issue? So maybe I'll start with you.
So it depends on that situation. Did that patient in front of me have no problems with that original? I do everything I can to keep them on what they were on, do a prior authorization or whatever I need to do if that's the drug I wanted them to be on for whatever reason. Maybe it's the pleiotropic effects that I want them to be on that. But depending, sometimes I'll start lower or sometimes I'll start one step up, and it's not on label. I might step a little bit higher. It depends.
I have to say, I'm probably a little too conservative with it. And so I supervise a lot of fellows in clinics, and some of my fellows are like switching people over to a little bit higher dose than I ordinarily would. So far, it's been going okay. And so maybe I just need to be less old-fashioned. Again, I think it has to do with what the dose is of the current GLP-1, for example, that they're taking, and how well it's been tolerated historically. Like for somebody, again, where it was really hard to get them up to like the max dose of dulaglutide or whatever, you're probably going to want to be fairly conservative.
For sure. So everyone has an individual, patient-specific.
Yeah, and I think sometimes we end up switching, and every medication has its own independent set of side effects for any given individual. And so if you had lower GI side effects with one, it is still worthwhile to switch within the class because you may not see it with the other. And I was a little bit like you, but I actually am doing a little bit more equal estimated dosing. And people seem to be doing well.
And the other thing I would point out is it's probably okay to switch to, technically a lower dose if you're switching to a more potent agent, right? Because if you're making a switch to a more potent agent, you might achieve a similar metabolic result with what technically seems to be a somewhat lower equivalent dose.
So there is a question here lots of questions actually, about the use in type 1. So I utilize the GLP-1 receptor agonist, not primarily for its glucose lowering effect in type 1, but if I can reduce insulin, I can help them with weight reduction, and I'm making the jump for potential pleiotropic benefits in those patients.
There's certainly ongoing study for that. It's not indicated, but if we're looking at pleiotropic effects and the weight loss too, so I feel everybody deserves to have appropriate and effective and safe obesity treatment if that's necessary. But what we're seeing is when you are doing that off-label, being able to reduce insulin doses even in people with type 1 diabetes, certainly with people with type 2, which we never really kind of got an opportunity to talk about, but that's why the ADA, standards of care, recommend injectables as the first injectable over insulin, which is the opposite of what we used to do years ago. But don't forget to lower insulin doses if we're doing the opposite. And that's what we're finding in type 1 diabetes also.
Yeah, and there were data presented at ADA this year that suggests that semaglutide is a reasonable complementary therapy in people with type 1 diabetes who also had overweight and or obesity. So this is probably not a treatment that you want to give to a lean person with type 1 diabetes because you're not going to really gain very much. And we can't say that it will improve their cardiovascular and kidney outcomes benefit at this time. But it can help you cut back on insulin doses in the person with type 1 diabetes who is also insulin resistant. But we do need to be careful not to cut back too much. And we need to be careful to manage symptoms or to, again, titrate up slowly, because if someone becomes very ill, has nausea, vomiting, they may hold their insulin and be at risk for DKA. So you have this extra concern in the person with type 1 diabetes that, there is the potential that their insulin doses will be cut down below what their basal requirements are, and that it would increase their risk of DKA. So we need to be sure that a balance is struck, and that we don't overdo in our reliance on what can be accomplished with the incretin therapy.
I'm going to unpack this question and put it into two questions. Lots and lots of patients have been taking compounded GLP-1s, and now they're kind of not sure what they should do because there's cost issues with prescription versus compounded. How do you handle that?
If you want to Google Goldman Wicked Good Cardiometabolic Chat, I did a podcast on the
Say it again.
compounded Wicked Good Cardiometabolic Chat out of Boston. So I did do something on this. I'm not, there are legitimate compounding pharmacies that follow all the rules and so forth, but that doesn't make it legal to do that anymore. There's not a shortage. But right now, it's flooded. The internet is flooded with, buy this, take this. We don't know where it's coming from. I have a friend, an endocrinologist friend, who had a patient using compounded, ended up in the hospital for 3 weeks in kidney failure, when in fact, that patient actually had coverage, drug coverage. So I don't recommend it. I'm not big on compounding. I would prefer to jump through every hoop I can to have patients have insurance coverage of whatever insurance, and there's also now direct to consumer
Exactly.
To purchase at a lower price. Does that fix everything? No, it doesn't fix everything, but it's still improvement in access to patients with direct to consumer.
Yeah, I don't have a lot to add there. These were considered acceptable alternatives to pharma manufactured GLP-1s and other incretin-based therapies while there were shortages. But the FDA has decided that, I think in June, that the compounded formulations are no longer necessary and they're therefore not legal. So we can't really prescribe things that aren't legal. That doesn't mean that people won't continue to obtain them. But as you had mentioned, it can take a little bit of extra work to really explore how people might be able to obtain essentially the official formulations, and there are more and more options to do that all the time at better and better prices. That's probably a better route for them.
I've also used patient assistance programs.
Absolutely.
So I've used the patient assistant, even patients who are insured. So
Yes.
if they're underinsured or they have Medicare, I have done that. So.
Yeah, Medicare is almost the trickiest one when they get in the donut hole. For Medicaid in most states, now this is for diabetes management, in most states, there will be a GLP-1 receptor agonist that with demonstrated outcomes benefit available on that formulary, but it takes some work to figure out which one it is, and it probably changes each year as they revamp the formulary. But people do have options. It's just within our system, it's really difficult to figure out what they are.
Yeah. And it's really important, at least in the West Coast here, if you're writing a GLP-1, you actually have to put the indication in the SIG, because the indication has to match the medication indication. So when I write, semaglutide for obesity and I put the obesity code, I'm much more likely to get covered if I'm writing the right brand medication with the right indication and it's in the SIG. So make sure that you do that.
And speaking of Medicare and donut hole, so that's gone now. So there's no donut hole anymore. So if you have patients on Medicare, it's now maxed. So it's like $2,000 for the year that they're going to spend outwards. So what you want patients to do is at the beginning, they need to contact their plan and have it spread out over those 12 months, or they have to pay that $2,000 up front. But that also makes accessibility of these classes of drugs for that population so much easier versus what we had before.
The other thing that's really exciting is that a lot of these agents, as well as SGLT2 inhibitors, are on the list of like 15 additional agents that Medicare will be negotiating prices for in the coming year or so. And so we might actually see that for our patients with Medicare, costs come down really significantly. And what you tend to see is if the Medicare prices change, often there's kind of a ripple effect throughout other types of coverage. So hopefully we will see that. Did you want to talk about changes in body composition, et cetera? Yes. So this is a hot topic. We should have probably touched on this a little earlier, but the very potent incretin-based therapies result in quite a bit of body weight loss. It is not all adipose tissue that is lost. When you kind of compare the effects of weight loss with incretin-based therapies on what is called lean body weight or lean body composition, it's probably comparable to what you see with metabolic or bariatric surgery, might be a little bit more. And also, it's important to remember that in the trials where body composition was actually followed in a rigorous fashion, they used DEXA, which is probably not the very best way to determine the effects of the weight loss, specifically on muscle. So lean body mass is not just muscle, it's organs, it's fluid, it's cells, for example. And so we don't have quite as much information as we would like, but it's a concern for the person, for example, who really loses a tremendous amount of weight, who might be a little bit older and more frail at baseline. At present, I don't know that there's a lot that we do beyond exercising good common sense and not treating with doses that are higher than physiologically necessary, and maybe backing off on a dose if we see someone becoming a bit weaker and what appears to be sarcopenic. There are recommendations that people participate in resistance exercise and to make sure that they're getting an adequate amount of protein in their diet. It may be worth sending them to a nutritionist or dietitian again to talk about that. And then there are a lot of other newer medications in development that are being considered as therapies to give alongside, for example, these potent incretin-based therapies that might have a bit of a muscle-preserving effect. All of these are in early stages of development. They're probably going to be very expensive if and when they are approved. And there are also newer anti-obesity medications that are being studied that at least it's claimed to have a bit less of an effect on the loss of lean body weight. But again, that's all to be determined. I think just the most important thing is don't overdo it with the dose. As people age, they're probably going to be on these medicines for many, many years, and our requirements, our bodies change as we age. And even though somebody needed max dose semaglutide at one point, they may not and probably will not need that forever. So it's very reasonable to regularly reassess and see if we can down titrate and maintain the same or even an individually preferred outcome with the lower dose.
So there is one here about a patient who had a significant local injection site reaction with tirzepatide. What do you think the mechanism is, and is that a medicine or incipient or?
I don't know.
Yes.
I mean, I think where anything we inject into our body, we certainly have a risk, and some people are more at risk than others. You know, some people it's adhesive, some people, so I would say avoid that one, you know. in the future.
And more often than not, it is an incipient problem than the medication problem.
Usually.
Exactly. And if it happens right away, it's not an antibody issue. They don't
Sure.
have antibodies yet. But yeah, we have options. Try something different. Make sure that when they start the next one, that someone's there with them to observe how they're doing. But fortunately, that seems to be very, very rare.
Yes,
in my
I have never seen.
experience.
I
It
haven't.
I very rarely do my patients complain.
Yeah.
So this is a relatively straightforward one. If you have a potentially reversible cause of pancreatitis that has been reversed, at least I'm not uncomfortable using these agents. However, if it's a recurrent concern, alcoholism, high triglycerides, you need to make sure that underlying condition is addressed before you use these agents.
I agree. And one thing that is kind of left out a lot of the discussions of the clinical trials data is that in almost all of the trials of GLP-1s or dual incretin therapy, patients with a history of pancreatitis were excluded. So the people who were studied were already people who had not had pancreatitis before, and that's not representative of the entire population. So the results are a little bit biased towards a patient population at lower risk. So we need to exercise good clinical judgment. If somebody has had recurrent pancreatitis because their triglycerides are completely out of control, because they're drinking, sometimes we have people, I have a lot of patients, unfortunately, who've had idiopathic pancreatitis on more than one occasion. That's tricky. These are probably not the next best step for those individuals. It's tough when that happens.
What about the discussion about new evidence about non-ischemic anterior optic neuritis? What are we telling our patients? I know it's only been seen in a couple studies.
They ask that. People are on the internet. They come in and should I or shouldn't I? Which is interesting because people will buy things off the internet and inject themselves. So here we have this drug that has all of these, wonderful outcomes and proven outcomes and cardiovascular endpoints. So I do. Listen, we're making sure that you're having, an annual dilated eye exam. We're taking a look at all those things. Right now, it's unknown. It's considered to be rare. I'm not going to force you to do anything. What do you think? And let people decide.
Yeah, I think this is an area that we need to learn more about. I'm not sure that I personally understand what the phenotype is of a person who's going to develop that complication. I would like to think that if I have my patients' cardiovascular risk managed well otherwise, that might reduce their risk, but I don't know that that is the case. In my patients who have fairly advanced retinopathy, I always check with their ophthalmologist to make sure it's okay that I'm going to start one of these medicines. They never say no, though. But I feel like it's a courtesy. Maybe at some point they'll be a little bit more up to date and have other input. But what I think is very important, just from a retinopathy perspective, is to not start somebody on a potent incretin-based therapy when their A1C is 12, right? Because then the likelihood is that you're going to drop their A1C a lot and quickly with these agents. So try to get their A1C a little bit closer to goal so that you're not going to drop them tremendously when you start the GLP-1. You can do it and then gradually up-titrate the GLP-1 and decrease, for example, their doses of insulin that they're on so that the improvement in A1C is a bit more gradual. That is something that I do from just a safety perspective, which I hope is helpful. I would note that there is an ongoing semaglutide trial called FOCUS. I don't know when it's going to be concluded, but that is a dedicated retinopathy study that I hope will shed a lot of light on what we understand are the effects of, in particular, semaglutide therapy on eye outcomes. But I also really wish that I knew what type of person is at risk for this specific type of complication. I just don't have a good feel for that right now. I talk about eye problems and the risk of worsening eye disease with patients who are starting these medications, but it's hard for me to say, in particular, I'm worried about you getting this with what we know now.
Well, Dr. Goldman, Dr. Green, thank you both. Thank you all for your active participation today. We hope you enjoyed it. Please make sure you do your post-test and do your evaluation and enjoy the meeting.